What is going on, guys? Today we're going to be looking at bone tumors, specifically in this video focusing on the benign bone tumors that are mostly common in adolescents and children. And then we'll get into, when we talk about some of the malignant bone tumors, how some of those are more common in the adults, older adults, and then even one type being very common in the elderly. So for the focus of this video, I've gone ahead and drawn a line separating the very top four is going to be the benign bone tumors, some of the most common ones that you'll encounter on board exams and in clinical practice. And then the bottom four is going to be some of the most common for the malignant bone tumors. And then this last one that I put in parentheses is not technically always considered a bone tumor. It's really a plasma cell dyscrasia or a plasma cell tumor. But it often will go to bone to kind of hide away. And it usually will go and hide in the vertebrae or the lower back that we'll talk about in another video. So we're going to be focusing on these four in this video. Okay, so let's get right into this. The first one is osteochondroma. I always break down the words first to see if that will give us any indication of what we're dealing with. So the first thing you have to remember is this is the very first benign bone tumor that we're going to talk about. So you know the difference between benign and malignant. Benign is just saying that it doesn't have the potential to metastasize in most cases, and malignant are usually more dangerous with penetration past the basement membrane and into surrounding tissues with ability to metastasize. So osteo refers to bone, and then chondro refers to cartilage. So this is going to be a type of benign bone tumor where you have something called an exostosis. And an exostosis, all that really means is that you're having new bone growth on existing bone. And then where osteochondroma comes into play is that when you have this new bone growth on existing bone, for example, in this picture over here shown, this is an exostosis. I'm just going to abbreviate this. Exostosis. The actual tumor itself, though, is going to be an exostosis with an overlying cartilage on it. So maybe farther down from this exostosis, you would actually have some of the cancer here. And the bone tumor cancer that here is going to be basically the same thing, an exostosis, but it's going to have a cartilage overlying it, and that's what's called an osteochondroma. So what causes this? It's going to be pretty simple. Exostocin 1 and 2. So that just as we see exostosis or exostoses in this type of cancer bone tumor that often presents, you will have a mutation in exostocin 1 and 2. And that's going to cause altered heparan sulfate production or differentiation that's needed at the growth plate specifically. So remember that you have the diaphysis. So I'll just kind of draw a quick little bad drawing of a bone here. The diaphysis is going to be at the middle. It's basically the bone shaft, the long part of the bone. And then you have what's called the metaphysis. And then at the very top part of the edges of each bone, you have the epiphysis. Okay? And then nearby the metaphysis, you're going to have kind of like up in here is going to be what's called the physis or the bone plate. So the heparan sulfate that is needed to help in the function of the bone plate to basically grow for your bones to grow during puberty and whatnot, growth spurts, that is what's being altered when you have a mutation in this exostocin 1 and 2. So that's kind of what they think causes this osteochondroma bone tumor. Now, where's it located? It's in the metaphysis of long bones. So you will often see, the way I remember that is this. If you know, like what we just drew out, here's a bone again. If you know the general kind of setup of a bone, you know that the metaphysis stands for the middle, and it's called a metaphysis, or kind of like referring to middle because it's in the middle of the epiphysis and the diaphysis. And you'll see some resources will say that, you know, the physis or the growth plate is not in the metaphysis, and you'll see others that say it's actually kind of part of the metaphysis. So regardless, it's either a part of it or very close to it. So this is the metaphysis. So when you look at the title, osteochondroma back up here, just looking at the name of this and knowing that this has cartilage within it, you should know that there's tons of cartilage within the growth plate, and that's kind of what helps you to grow. It uses basically cartilage to build up your bones and to cause you to get taller. So just looking at the title, you should have an idea of where the majority of these cancers are going to show up. They're going to show up in the metaphysis of long bones for the most part. All right, so that is an osteochondroma, and let me clear all the writing out and show you. Over here, this is the exostosis, which hints greatly at an osteochondroma, and look at the location. It's right here at the metaphysis. Before, the epiphysis was right here, and this is all the diaphysis. So you see that the cancer is actually at the most characteristic spot, and it has that exostosis, which should help you hint towards that this is an osteochondroma. Okay, so let's get to the next one, giant cell tumor. In this particular example, again, we're going to look at what it says, giant cell tumor. I want you to remember kind of that giant cells, kind of what they look like. They're multinucleated giant cells. So they have tons, and they kind of look like this. This is just a rough estimate of what they look like. There's something else that looks very much like this and is also kind of considered a precursor to these or an aftercursor. And you could say an osteoclast looks very much like giant cells. So this is a giant cell tumor, and this is an osteoclast-derived tumor. And if you look at histology, you'll see a bunch of these giant cells. And in just knowing that this is osteoclast-derived, because naturally they look the same. So, giant cells are from osteoclasts, like I said. Now, where are these located? They're in the epiphysis of long bones. So you're going to see as we go through a lot of these, they're in different locations, they have different characteristics, and I'm always going to try to give you a hint to help you remember, okay, where are these located? How do I remember all of this in the scheme of things? How do you remember that this particular example is at the epiphysis? Now, let me remind you again. Here's a terrible drawing of a bone again. The epiphysis is at the ends of long bones. So how do you remember that the epiphysis is at the end? Well, I want you to remember that when you think of long bones, the biggest part of the long bone is always at the end. You always notice that it goes to kind of a bigger part at the end. It's more skinnier in the middle. It's a little skinnier at the metaphysis, but the biggest part, or the most giant part, keyword, look at the word giant, is at the epiphysis of bone. So that's how I remember. When I think of a giant cell bone tumor, I can remember it's at the epiphysis because that's the most giant part of the long bone. So that's just a little tip to help you remember. This is commonly presenting at the epiphysis of long bones. Look at the picture over here. The picture is showing the end of a long bone, and look where the cancer is. It's right here in the epiphysis at the biggest portion, or you could even say the most wide, both of them are correct, portion of the long bone. So what is a characteristic of this? Let me clear all of this. What's the characteristic of this particular giant cell tumor that you need to be looking for if they show you an X-ray? They call it something called soap bubble appearance on X-ray. So it's a large multicystic lesion, and let me zoom in and show you why it's called soap bubble, because it's kind of hard to see here. If you look here in this particular example, you will see that there is many, it's not just one large mass. I mean, it is a really large mass here, a multicystic kind of tumor here, but that there's also many kind of like little circles and little design throughout this. It almost looks like it's kind of like a spider web or a bunch of soap bubbles that have stacked on top of each other within the one giant bubble. That's what gets it the name, the soap bubble appearance. Okay, so let me zoom back out here. So we've talked about that now, why it has that soap bubble appearance, and that's something you want to look for. And where is it going to be? It's going to be in the epiphysis of long bones, most commonly. Now, the things I'm telling you here, these are the most high yield points. So you may say, well, I know somebody who had it in the metaphysis, or I know somebody who had it somewhere else, and it wasn't a long bone. I'm giving you kind of what's to be known as the most common presentation. So, and this one is mainly in adults, so that's also something to keep in mind, because most of these that we're going to talk about are either in adolescents or children. This particular one usually presents in adults, just kind of a general age of adults. Okay? All right, so the next one, osteoblastoma. Let's look at the word. Osteoblast. We know what osteoblasts do. Osteoblasts help in the production of bone, or the buildup of bone. So osteoblastoma is osteoblast. And what do osteoblasts do? They build bone. So you're having a bone tumor, or a tumor of the osteoblast. So this is a benign, again, this is a benign but locally eroding bone tumor of osteoblast. That's important. And I'm going to show you why when we look at the next example. So what is the characteristic of this particular bone tumor? This has something called a nidus that you'll see, or nidi in plural, you could say. And it looks a lot like a cannonball blast. So if we were looking at this particular cancer, which, by the way, is not in the long bone, it is actually most commonly presenting in the axial skeleton. And in what section of the axial skeleton is it most common? In the vertebra. Now, there's a way that I remember this. How do you remember that it most commonly presents in the vertebrae and thus in other sections of the axial skeleton too? I look at the word, and this is how I pronounce it. I don't pronounce it osteoblastoma. I pronounce it as osteobrickoma. Deliberately saying it wrong, because if you think of like bricks that are used to build a house, bricks are stacked upon each other to build a structure, right? They basically stack, like, you stack tons of bricks on each other, and then eventually you have a big wall of bricks, and that's how you can build a structure or a house. That looks a lot like vertebrae. Vertebrae are, stacked upon each other, and then you have the spinal cord inside. So that's really the only thing that's of bone that is in this kind of way, that stacks on top of each other in the entire human body, is the vertebra. So that's how I remember when I see osteoblastoma, I say osteobrickoma, and I remember, oh yeah, this is the one that's most common in the vertebrae, and that should remind you, where's the vertebrae? What is the vertebra the part of? Which particular skeleton? Is it the axial, appendicular? And it's going to be the axial. So this bone tumor presents all over in the axial skeleton, the most common being the vertebra. And then when you have it in a vertebrae, for example, say this is a vertebrae, here's a stack of them, and the cancer is, like, let's say right here, you're going to see what's called a nidus. We're going to go back to this. This is the central part of the tumor itself, at which kind of where all of it is basing out from. So it starts, there's a central nidus. Now it's going to be rather large. So if this was the bone tumor, the nidus is going to be very large in comparison to the tumor. That's very important, because in the next bone tumor we're going to look at, it also has niduses involved, or nidi involved in it, but they're going to be smaller, and they're going to have another distinguishing characteristic of having a sclerotic kind of ring or halo around it, whereas this one doesn't really have that sclerotic tissue at its periphery of the nidus. It just has a solid, really large nidus. Now, how do you remember all of these characteristics? I told you how to remember about the vertebra. We know that it's benign because those are all the ones we're talking about. We know that this is a tumor of osteoblast, but how do I remember that this in particular is going to be a large nidus without a sclerotic halo around it? Well, think of a cannonball blast. A cannonball hits say a pirate ship or something, and it makes a huge blast radius. So I think of a cannonball, it's really, really large. It's not small like the small niduses in the next particular disease we're going to talk about, or tumor, I'm sorry. So who does this present in? Remember what I told you earlier, the majority of these that we're going to talk about are presented in usually adolescents, young adults, or children. And the one exception was the previous one, which was mainly in adults. So this age group is strong enough to be able to blast anything. So that helps you remember the two age groups that this is most common in, adolescents and young adults. That's the point of your life where you're most strong. And I think when I see osteoblastoma, a huge blast, that's a lot of strength and power behind that. So that's the age group where you would see that. Young adults and adolescents, kind of the peak of your life. And then the pain is worse at night. And look what I put in red. This is so important, because when I was studying up on this the other day, I saw, okay, there's some types of cancers where the pain is worse at night. And it's common in osteoblastoma and the next one we're going to talk about. But there's a distinguishing characteristic. And this will make sense to you. Let me clear the screen and explain why. In osteoblastomas, you have a large nidus, right, that I talked about. How do you remember it's large? Because think of blastoma, like a cannon blast. So you have this large nidus, but it has no ring around it. So this is not present. And that sclerotic ring just happens to have a lot of prostaglandin in it, if it would be present. The next one you're going to see will have this prostaglandin ring. Remember the function of aspirin. Aspirin works by inhibiting a certain part of the arachidonic acid pathway that steroids can also inhibit. So that will eventually inhibit prostaglandin. So if this nidus sclerotic ring is not present in osteoblastoma, naturally aspirin will not work, because prostaglandins cause what? Pain. So the pain is really more or less because the tumor, the nidus and the tumor itself, is far bigger than the next one we're going to talk about. And so therefore, if it's not prostaglandin causing pain, it's other factors causing pain, like the size of the nidus and the bone tumor itself. So aspirin is, this pain, which is worse at night, is not relieved by aspirin. Okay? Now, We're going to get into the next one. This is the one where they can try to confuse you. Osteoblastoma versus osteoid osteoma. Now this one, osteoid osteoma, it is an osteoblast and osteoclast mixed bone tumor. And there's some debate on this. I've seen different descriptions of this bone tumor, but that's the best way to remember. It's got a little bit of osteoblast and osteoclast involved in the tumor itself. Now, this is typically in the cortex diaphyses of long bones. How do you remember that? In other words, what does that mean? What is the cortex of a bone? When you look at a long bone, the cortex is really just the outer surface that that would be going all the way around and making a circle around this bone. It's the outer surface of a long bone or a bone. That's called the cortex. So this particular bone tumor is not going to be buried inside of the bone. It usually presents somewhere on the outside as an outpatching or kind of on the surface or whatever. So that's where an osteoid osteoma usually presents. How do you remember that? Because if you look at the title, Osteoid Osteoma, what is osteoid? Remember that osteoid is that kind of pre-mineralized or pre-calcified, you can say either way, pre-mineralized bone. And if you remember back to primary ossification, which is involved kind of in the building of bone, the primary ossification is the first parts. The bone is initially built from the outside. Now, I know there's more to it, and there's a lot of steps, complex steps of endochondral ossification and all the different types of other ossification. It's all really confusing, but just know in this particular example, in long bones, the ossification primarily starts from the outside. Okay, so that should help you remember. If you need osteoid and it's starting from the outside and this tumor is altering this pathway, it's messing with the osteoid in essence through the osteoblast osteoclast mixed bone tumor, it's naturally going to present at the outside because that's where the ossification, primary ossification involving osteoid happens. Okay, so that's how I kind of keep that straight for the location of this particular bone tumor. And then don't just remember that, also remember that this is in the cortex, well yeah, but it's in the diaphysis specifically of long bones. So it's going to be in this particular like shaft part. It's not going to be at the metaphysis, it's not going to be at the epiphysis, it's going to be at the bone shaft itself. And that's where the bone shaft is where the primary ossification begins at the cortex. So that should make sense as well. Let me clear all of this mess up. And then I said earlier, the complex part of this is that you have a nidus in both osteoblastoma and osteoid osteoma, but the differences is in the size. In the particular example of osteoid osteoma, they're usually 1.5 centimeters or less in size, somewhere around there. Different sources say different ones, but basically you need to know this is a really small nidus that you will see in this particular cancer. So if we draw another bone here, remember we know it's on the cortex, so the outside part, we know it's at the diaphysis, so say here's the cancer right here. So then you will have a nidus, but it will be extremely small. But there's something else special about this nidus. If I were to zoom in on this right here and bring it over here, here's the nidus. I'll make it a little bigger. This particular nidus has this sclerotic kind of periphery to it that's around the nidus. And the periphery of this nidus has a lot of prostaglandin. Now, look how important this is. So the patient will say, oh, I've had bad pain at night, but this particular example, you'll say, okay, did you take aspirin? Or did you take whatever, salicylates of any type? They'll say yes, and it made it better. The reason it's making it better is because it has this sclerotic kind of fibrous periphery around the nidus, and that has so much prostaglandin in it, but aspirin can indeed decrease your prostaglandins through the arachidonic pathway that we talked about. That's why in an osteoid osteoma, aspirin will help relieve some of the pain that's worse at night, whereas in this one, in osteoblastoma, the pain is still worse at night, but it's not helped by aspirin. That's a very defining characteristic. Okay, so that is osteoid osteoma. Now let's get into some of the pictures. These are pictures of osteoid osteoma. Notice, the first thing you notice, look, it's at the periphery, and it's at kind of the starting point of the diaphysis here. Okay, then look here. There's something really hard to see, and I'm going to try to zoom in so I can show you this really difficult to see in this x-ray. Do you see right here, there's a little, actually let me zoom back out so I can still write at the same time. there's a, if you were to zoom in right here, you see that little kind of lucency there? That's the nidus itself. Now look all around the nidus. You see all this kind of like fibrosis and sclerosis? That's the periphery I was talking about. That's filled with prostaglandin. Therefore, aspirin will help with the bone pain that presents at night in these patients. Now look over here at the MRI. So this is an MRI. The one we just talked about is an X-ray, and then this is the CT. Look over here at the MRI. You can see a clear, very good picture of this nidus. So here's the nidus. I'm sorry, yes, that's actually the nidus periphery I just pointed to right there. So this is the nidus periphery that's filled with the prostaglandin, and then look at the center. There's the nidus itself. And you can see that sclerotic border that would not be present in the osteoblastoma in most cases. And then in the CT scan down here, it's just showing again that nidus that's there with the sclerosis in the periphery around it. Okay, so you can see in all three of these imaging modalities here. All right, and that is the kind of the predominant, most important benign bone tumors that you can see most commonly in children and some adolescents, and then I gave you the one example where it's usually in adults. Okay, so jump on over to the next video that I'm going to be having on my channel, and it's going to be the next one is going to be covering the malignant bone tumors that are most high yield. And actually, in the case of malignant bone tumors, the most common bone tumors overall are mostly in the malignant bone tumors. Okay, so jump on over and check that video out, and I will catch you in another video. Bye, guys.